All right, so the cardiovascular system is my favorite of all the systems. At the bedside, I was a tele-nurse, so maybe it comes from there, but also because we see so many chronic issues with the heart, at least in the adult population. We see hypertension, heart failure, cardiomyopathies, AFib, all kinds of stuff. So let's get into this complex but ever so important system and go through some of the diseases that our clients face. You all know this, so quick review of the cardiovascular system. Circulation, we know, is divided into two systems, pulmonary and then systemic. The lungs exchange CO2 and oxygen in the alveoli, and then the heart carries that oxygenated blood and nutrients to systemic circulation to do the work of the body. Without that gas exchange and healthy pump, our clients are going to develop issues. So whether it's lung disease or heart disease, it might even be both. So we've got blood flow through the heart, and then we have conduction, right? That heartbeat. Remember, the SA node is the pacemaker of the heart, and it's where that first impulse begins. Then it goes to the AV node, then the bundle of His, down the right and left AV branches, and then finally to the Purkinje fibers. On this slide's a normal heartbeat. So the P wave is atrial depolarization, or when the atria are contracting. And when the atria depolarize, the ventricles are filling. So at the QRS complex, our ventricles depolarize or contract while the atria repolarize or fill. And then the T wave represents ventricular repolarization, or when the ventricles are relaxing and getting ready to contract again. Any alteration in the action potentials are going to alter our client's heart rhythm. Finally, we have blood that feeds the heart right through the coronary arteries. So these arteries, we know, supply rich oxygenated blood to the heart. And disease of these vessels, as we're going to learn later, is what makes clients at risk for myocardial infarctions when these arteries get clogged or blocked by clots. Several things control the heart and its beat, right? The cardiac control centers in the brain, in the medulla oblongata, which controls the rate and force of contraction. Then there's sympathetic stimulation via a cardiac accelerator nerve that increases the heart rate, while the parasympathetic stimulation is caused by the central nervous system and then the vagus nerve, and that slows the heart. We also have baroreceptors in the aorta and carotid arteries that detect changes in blood pressure. So remember, blood pressure is directly related to the blood volume, which is affected by hormones. We've got antidiuretic hormone, and that's released as blood pressure is lowered to retain water and increase blood pressure. Then we have aldosterone, and that's released to increase blood volume, thereby increasing blood pressure. And then the renin-angiotensin-aldosterone system in the kidneys causes vasoconstriction and thereby increases blood pressure. How much blood's ejected by the ventricle each minute is the cardiac output, and this is dependent on the heart rate, but also stroke volume, which is how much blood is ejected from the ventricle with each contraction. So all of this is going to come into play when we talk about heart failure and cardiomyopathies shortly. So what are the risk factors for heart disease? We've got 4 that are non-modifiable. Your age. The older one gets, the greater the risk for heart disease. One, sex assigned at birth. Those born male at birth are more likely to develop heart disease. Family history and diabetes type 1, which we know as an autoimmune disorder is when the body doesn't make insulin, right? The pancreas isn't working. The majority, though, are modifiable, and this is where the education comes from you as nurses. Their diet, tobacco use, illicit drug use, those that have high blood pressure, hyperlipidemia, diabetes type 2, physical inactivity, obesity, and then excessive alcohol use. While each disease process has differing signs and symptoms, here are the most common ones that we'll see. We're going to see chest pain or angina or angina, right? It could be crushing, squeezing, or even just mild discomfort. Either one could be a sign of cardiac ischemia. Shortness of breath or dyspnea may develop with heart failure due to the fluid buildup or fluid overload, especially when the client we know is laying down or during activity. Coughing or wheezing could also be a sign of fluid backup. Swelling in the peripheral extremities could be a heart problem due to narrow blood vessels. And then this is going to cause pain, achiness, or burning, maybe even numbness of their feet or extremities. Fatigue. They're just tired all the time, right? Tired with exertion, but then eventually tired just while resting. And even palpitations of the heart, right? Feeling like the heart is skipping a beat. And then finally, dizziness or signs that come in the central nervous system. These are early warning signs that the heart may be compromised. So this is what we want to educate clients. There are also several tests used to diagnose heart disease. The first is an electrocardiogram or an ECG, and that's going to look for the electrical signs of the heart, for arrhythmias, even myocardial infarctions. Chest x-rays are useful for seeing fluid or if the heart is enlarged. Blood tests are helpful as well. A CBC is going to show red blood cells, hemoglobin, white blood cells, even troponins. Those are proteins found in muscle, including your heart. So when the heart muscle is injured, troponin is released into the blood. So typically troponins are ordered every 8 hours to look for changes when we're looking at if a client's had an MI. Lipids may show the risk for hyperlipidemia, right? And then random glucose levels for diabetes, which put them at higher risk. Some providers order exercise stress tests to reveal how the heart responds to physical activity. Echoes or echocardiograms create detailed images of the heart in motion and then show blood flow through the heart and the valves. A cardiac cath can show blockages in the heart arteries. And then MRIs create detailed images of the heart. And then, of course, and we can't negate the physical exam. Let's talk about some valvular disorders. So valvular disorders also affect cardiac output as blood flow is either decreased by stenosis or it's flowing backwards through the valves, and that's regurgitation. So stenosis is the narrowing of the valve, and the blood moving through is reduced because it backs up into the chamber before. The heart has to work harder to get past this narrowing. It's kind of stiff, which then causes the chamber to hypertrophy and then work harder. However, the cardiac output's diminished because that blood can't move forward normally. And then that leads to certain forms of cardiomyopathies and heart failure. In regurg or regurgitation, the valve's incompetent, and so it doesn't completely close. So the blood flows in both directions. And this increase in blood to be pumped and increase in cardiac workload, again, leads to hypertrophy of the chamber. In regurg, the murmur occurs when the valve should be closing, so while it's filling. So in mitral regurgitation, you're going to hear a murmur during systole. Cardiomyopathy literally means disease to the heart muscle, and that leads to changes in the structure and function of the heart. And so this slide has the nuts and bolts differing the types of cardiomyopathies. Dilated cardiomyopathy is when the ventricle is dilated, but there's normal wall thickness. So it leads to systolic dysfunction. It has a reduced ejection fraction, or how much is being ejected from the ventricles. It also leads to mitral regurgitation and then left-sided heart failure. So you're going to see all those respiratory signs like dyspnea. You're going to hear crackles, things like that. Hypertrophic cardiomyopathy is when the ventricle is thickened, typically the intraventricular septum, so between the two sides of the heart. Ejection fraction here is normal, but there's mitral regurgitation and then left-sided heart failure signs again. Just as dilated cardiomyopathy, it can lead to AFib, VTAC, but also sudden cardiac death. And this is what we typically see in young athletes when they suddenly die. Finally, we have restrictive cardiomyopathy, which leads to rigid ventricular walls, but with normal thickness. They're just not as compliant anymore. They don't move as well. And this leads to diastolic function and then right-sided heart failure. So you're going to see the signs like peripheral edema, GI disturbances, and enlarged organs. Again, this leads to AFib, VTAC, and heart failure. I added a great video to the module explaining the patho and then more of the differences in the cardiomyopathies. Another common disease process affecting adult clients is heart failure, which ultimately is when the heart can't pump enough blood to meet oxygenation demands. So there's a problem with ventricular filling or ejection, and even structural or functional impairment. We see hypertension and coronary artery disease as the most common causes. However, those with altered heart rhythms like AFib or cardiomyopathies, even valvular disorders, and substance abuse can lead to heart failure. So as the heart tries harder to pump, there's left ventricular remodeling, which means the mass, volume, and size of the heart changes. And that leads to muscle cell loss, decreased contractility, and the left ventricle dilates and hypertrophies. Right-sided heart failure, meaning the right side is weak, causes blood to back up into the peripheral circulation. And so these clients are going to manifest with those signs like peripheral edema, weight gain, distended jugular veins, and then even ascites in the belly from fluid buildup. Those with left-sided failure are going to present with the respiratory systems because the blood is backing up into the pulmonary system. Again, check out the video in Module 2 for week 4 for more on heart failure. The American Heart Association and the American College of Cardiology have a classification system for diagnosing heart failure. For A, they're just at risk. When we see a category of B, they have structural disease, meaning they can see the damage, but the client isn't showing any signs of disease just yet. And with stages C and D, the client is literally showing clinical signs of heart failure. We also have disorders that affect our vessels, and while your book covers more, I'm just going to review a few. Atherosclerosis is a chronic inflammatory disease characterized by thickening and hardening of the innermost arterial wall. So you see the risk factors on the screen. This is likely a precursor for the next issue we're going to talk about, which is a myocardial infarction. That plaque buildup could get to the point where it suddenly occludes a vessel. And we know there's tissue death beyond a clot and also rhythm changes. So you might see ST elevations on a 12-lead EKG. Ideally, we want to try to reperfuse within 90 minutes of onset for the best possible outcome. We've likely all cared for someone with hypertension, or at least know someone with hypertension. So it's one of the most prevalent chronic health conditions in the US and the leading cause for heart disease. And so we start to see the signs of hypertension with prolonged hypertension. Risk factors, again, include age. The vessels are less compliant as we age. Family history, those that are obese or physically inactive, tobacco use, and then a high-fat or high-salt diet. Primary hypertension is a condition that develops over time, while secondary comes on pretty rapidly. And then finally, we have shock. When the tissues and organs lack oxygen because of decreased perfusion, we ultimately have decreased oxygen delivery. In distributive shock, the vessels vasodilate, and that leads to decreased plasma or blood in the vessels, and then a lack of perfusion based on volume. For hypovolemic shock, there's literally no volume, so this could be from a hemorrhage, so organs aren't perfused. Cardiogenic shock results from a failed pump, meaning the heart can't contract or fill nor eject, and this happens a lot after myocardial infarctions. And finally, obstructive shock can be a result of mechanical failures. Septic shock is an immune reaction, and we could get, for interventions, we're going to get blood cultures, aggressively rehydrate, and then start the client on antibiotics. Okay, that's just a little overview of Chapter 4 on cardiovascular function. Again, the videos this week in the modules in Canvas, cardiomyopathy overview, and then a heart failure overview. And then assignments to complete this week. Your first case study is going to be over, I believe, heart failure and cardiovascular function. So have a great week.